the orthoPAC, hosted by Sam Dyer. Welcome to the orthoPAC, where we discuss up-to-date orthopedic topics for the busy clinician. I invite you to sit back and relax as I attempt to fill in the gaps between education, current events, and real-world practice.
Welcome back, listeners. Today we continue our discussion of overuse injuries in pediatrics with Dr. Randon Hall. Welcome back, Dr. Hall.
Thank you. Thanks for having me.
Listeners, Dr. Hall recently gave a couple of presentations at our Phoenix meeting, and this podcast is based on one of those talks. All right, so fifth metatarsal, we're just continuing to move right along. The fifth metatarsal apophysitis. And you described this as tenderness over that growth plate, kind of right along the base of the fifth metatarsal there. And you also showed some x-rays with the epiphysis. And I was just curious, have you ever seen one of these that was actually fractured? And then also wanted to ask a couple of questions about the x-rays. Do you do weight-bearing x-rays on peds, and do you do contralateral films?
So I would say I think that maybe I've seen one or two where I felt that the gap at the growth plate was wider than what I expected. But generally speaking, I'm going to use the history to guide me here. So I'll see this more with just, hey, foot started hurting, no trauma. Then I can feel pretty comfortable that, there's not any displacement of that piece or that growth plate. I have seen some cases where it was like I got kicked in the foot. Again, usually it looks pretty normal, and it's just that the physical exam demonstrates pain to that area. So I think in theory, yes, it is very possible that you can have a widened growth plate and a Salter-Harris 1 fracture of that proximal metatarsal growth plate. But I think that's pretty unusual. And I would say, to add to that, I would treat it the same way. So I'm not too concerned about exactly if it's a little wide or not. But as far as x-rays, I would say a little bit is trying to read the family sometimes. If you saw a patient who you thought had this, the history was correct, I would say I don't really need x-rays. But sometimes families, when they get to an orthopedic clinic, that's kind of what they're looking for. And so they may not be satisfied with that answer. And so I'm open to, hey, I think this is what we have. We can kind of confirm that on x-ray. And I think that satisfies a lot of families. I generally don't get weight-bearing x-rays. I don't think it's all that necessary. I would say the times where I'll do that, at least for the foot, is if I'm concerned for a Lisfranc ligament injury and looking for gapping and spacing. But I don't think you're provided any additional information on weight bearing for at least the foot. And then, the contralateral question is kind of a nuanced question. I would say in general, there's not many reasons that you need to get contralateral x-rays, but I think it just depends on your experience. The people who see kids all the time are very confident with kids. I think they would say we don't usually order contralateral x-rays. I know we'll get to this a little later, but I will mention there's kind of two situations where I will be helped by a contralateral x-ray, and that's with a gymnast wrist, so Salter 1 of the distal radius, and then little leaguer shoulder, so similarly Salter 1. Sometimes it is nice to see if there's true widening there. The reason is because the ramifications of the treatment plan are going to be significant. So shutting someone down for a long period of time, I want to be pretty confident. And so I will consider contralateral in those situations. But in general, most pediatric specialists would be very comfortable just reading the x-ray as is.
Great. I just, you see some patients sometimes, and if you're not sure, like you said, if you don't see pediatrics all the time, every day, you might want to consider that. But calcaneal apophysitis, as we're moving through the foot here, how do you manage this patient? What's your take on this? And please tell our listeners what you tell the parents about Sever's disease.
Yeah, I think this is one that is super common, and I think it's very challenging for the families. So the first thing I do is tell them, this is not a disease. It's just named after some old dude. And I think that kind of lightens the room a little bit and helps them. Because sometimes, if you say, oh, yeah, you have Seaver's disease, they don't recognize that as like, oh, this is just irritation to the growth plate. So I make sure we're all dealing with the same diagnosis. And then I tell them expectations. So I say, no matter what I tell you today, I don't think this is going to dramatically improve within a few days. I think that this is a process, and I do not think that you're going to have any long-term complications of this. So I just establish all of those things first, and then it kind of opens the families up to hearing what I'm going to say next. So the first thing is just, if it doesn't hurt it bad enough that they're limping, I'm okay if they continue to participate in activity. So usually limping or pain more than a 3 out of 10 is what I'll say as a cutoff to participation. I do suggest the heel cups. Also remember,
Dr. Hall, may I throw in there real quick? What he describes in his talk is called a Tuli's, Tuli''. I'm not plugging for Tuli's, but Tuli's heel cups, the ones that have like the little holes, or they're like little squares in the bottom. That's what he's talking about, as opposed to a gel spot or the little gel insert. I think that will be helpful. So sorry to interrupt your train there, but I just wanted to throw that in.
Yes, I find that product to be quite useful, even in families who have said, hey, I've tried the gel and it didn't work. And then a lot of physical modification. So what I may have like a soccer athlete do is, hey, let coach know when you start practice, you're going to start in your flats, and you're going to do all of the warm-ups and the conditioning in your flats. For the actual skill-based stuff, you're going to switch over to your cleats. And then if you guys do any conditioning to end, you're going to switch back into your flats. And I think that can be very helpful. So that's my strategy. I think also addressing some functional issues with the foot. So if they have basically a foot that doesn't want to sit flat on the ground, or they have tight calves, I will suggest some physical therapy. But time is how I work with them and managing the pain. And then I have had some very severe cases where they needed to go into a boot. I've had severe bilateral cases where I actually had to have the most painful heel on a knee scooter and the least painful heel, which was still quite painful, in a boot that was pushing the scooter. So it can be quite painful, but just taking a very calculated approach is how I go about it. But making sure they know it's not going to improve quickly is very helpful.
The next one, shin splints. If you don't mind, please telling your views about shin splints. And I know you said you did some personal literature review to kind of help understand it a little bit better, the treatments. Could you please go through that for our listeners?
Yeah, this was one that just really frustrates me, because I feel like the recommendations that I had been giving were very generic and not super useful. And I really didn't think that I was getting great results with these patients. I think they were like, yeah, I'm a little better, but I can deal with it. And I was hoping to find something that was very useful and actionable. And so I just did a deeper dive and put a talk together specifically related to shin splints. And I found a few things that I think were agreed upon in the literature. I think what can be challenging is that there are some competing theories on why this occurs in the first place. So I think if you believe that it's from the pull of the calf muscles coming from the medial tibia, then yeah, I think that makes a lot of sense that stretching would be very helpful. If you go and pull a netter out and an anatomy text and look at the distal 1/3 of the tibia, you'll see that there are no muscle attachments there. And so the question being, if the calf does not attach to that area, then why does the pain occur there? And that's what maybe really opened my eyes to say, maybe this is not due to tight calf muscles, but more due to a mechanical bending force of the tibia when the foot hits the ground. So basically a ground reaction force. And that's really what I took as my leading, I guess, theory on why this occurs. And so there are a few things that can be utilized to maybe help in this. So again, I'm not against stretching of the calf, but I think just sitting around stretching the calf all day may not be all that useful. I think that you can certainly try orthotics in this case to help with the impact of those ground reaction forces. I also think that pre-training and slow workup can be helpful. So we use about 10% increase per week in the off season. I have also found that using like a shin sleeve, so like instead of like a knee compression sleeve, a shin sleeve can be helpful. I think it gets it to just creating a greater stability around the bone. And then instead of stretching the calf, working on significant anterior compartment, so tibialis anterior and posterior compartment, gastroc, soleus, strengthening to stabilize the, and I don't mean in a loose situation, but just to bolster the tibia can be helpful. One of the things I also found in the literature was hip internal rotation deficits. So if it's very easy to check, so just having the patient lay prone, knees together and try to rotate the hips out, just kind of like your fader maneuver. And if you get some restricted motion there, that may play some role on how the foot hits the ground and how that ground reaction force causes the shin splints. But that's kind of my overall go-tos in terms of like strategies that I will try. I can't say that it's day and night difference, but I feel like I'm giving people at least some evidence-based data to go about handling their shin splints.
What about chronic shin splints versus a fracture? When do you start thinking about further imaging?
So a little bit depends on what the athlete has coming up, because if the athlete's like, oh, I'm in off season, I'm willing to rest and I'm willing to cross train anyway, obviously I would do x-rays, but if the x-rays are negative, I'd say it's very possible that you have a stress injury we can't see, but you're willing to do the treatment that I would prescribe anyway. I think we're just going to, proceed with that. If an athlete is in season and is in significant pain or has a limp, I will proceed with an MRI there to look for a stress injury in that situation, especially if it's been more than 2 to 3 months. That dreaded black line that you see on the x-rays is pretty rare, so I typically don't see that on just a plain x-ray.
Great. Listeners, stay tuned for next week when we continue our discussion of overuse injuries in pediatrics with Dr. Randon Hall. Please follow the Physician Assistants in Orthopedic Surgery on social media. Connect with us on Facebook, Instagram, LinkedIn, and Twitter. Please subscribe to our podcast. If this has been helpful, please take a moment to leave a review.